Hi, my name is Hayley Suchland, and I'm doing my presentation over scapular dyskinesis. The subscapular fossa is the origin of the subscapularis. The coracoid process is the anterior projection where the pectoralis minor, coracobrachialis, and biceps brachii attach. The glenoid fossa is the cavity that forms the glenohumeral joint with the humerus, and the acromion is the anterior projection that forms the acromioclavicular joint. Next is the anatomy of the lateral portion of the scapula. This includes the supraglenoid tubercle and the infraglenoid tubercle. The supraglenoid tubercle is the top of the glenoid fossa and is the attachment site for the biceps brachii. The infraglenoid tubercle is the lower portion of the glenoid fossa and is the attachment site for the triceps brachii. Now we have the posterior portion of the scapula, which includes the infraspinatus fossa and the supraspinatus fossa. The infraspinatus fossa is the lower portion of the posterior scapula and is where the infraspinatus originates. Next is the supraspinatus fossa, which is the superior portion of the scapula and is where the supraspinatus originates. The supraspinatus fossa is also smaller and more convex than the infraspinatus. Scapular dyskinesis is when the scapula doesn't move as it should due to surrounding tissue damage. Scapular dyskinesis has three different types, including Type 1, inferior scapular border prominence, Type 2, medial border prominence, and Type 3, superior medial border prominence. Type 1, or inferior dysfunction, has a primary external visual feature of the inferior angle as a result of the anterior tilting of the scapula. This inferior pattern is better visualized when the patient has their hands on their hips or during eccentric lowering from overhead elevation. This pattern is most commonly found in patients with rotator cuff dysfunction. Type 2, or medial dysfunction, has a primary external visual feature of the entire medial scapular border due to internal rotation of the scapula. As with Type 1, the Type 2 presentation becomes more evident when the patient has their hands on their hips or during active eccentric lowering from overhead positions. This medial pattern dysfunction most often occurs in patients with glenohumeral joint instability. Type 3, or superior dysfunction, is characterized by excessive and early elevation of the scapula. This pattern has also been referred to as compensatory shoulder hiking or shrug and is most often seen in patients with rotator cuff dysfunction and deltoid rotator cuff force imbalances. There aren't many mechanisms of injury for scapular dyskinesis. However, I did find a more popular one in patients who did have scapular dyskinesis. This included poor overhead mechanics. Some signs and symptoms of scapular dyskinesis include limited mobility of the shoulder, visual deformities, as you can see in the pictures to the right, which include Type 1, Type 2, and Type 3, as we discussed earlier. This also includes drooping of the shoulder, and the symptoms include tenderness, pain, increased muscle weakness, and noises during movement, such as crunching or snapping. Next, I'm going to talk about the special tests for scapular dyskinesis, which we will cover more and perform in class. This includes the scapular retraction, scapular assistance, lateral scapular slide, isometric scapular pinch, scapular load test, wall push-up test, and the Kibler technique. Some predisposing factors for scapular dyskinesis include incorrect body mechanics, overuse, previous injuries, kyphosis, which is the excessive backward curve of the spine, weakness of muscles, and flexibility issues. There are no differential diagnoses for scapular dyskinesis. To prevent scapular dyskinesis, one needs to strengthen the muscles of the shoulder, avoid overusing the shoulder, stretching and warming up before practices and games, using correct body mechanics, which includes correlating the body as one unit. To treat and manage scapular dyskinesis, one needs to stretch and strengthen the muscles that surround the scapula, avoid overusing the shoulder until the condition improves, teaching and learning proper body mechanics, kinesiotaping, muscle re-education, and possible surgery. Referral and immobilization for scapular dyskinesis includes physical therapy, which I will discuss in my next presentation, rarely an orthopedic surgeon, and often no immobilization. There are no Mulligan techniques for scapular dyskinesis. My PCAT analysis was over a 25-year-old male athlete who used hands-on therapy, exercise, and proprioceptive neuromuscular function to increase his range of motion of the shoulder in just 6 weeks.